Please continue.
Okay.
This meeting.
Let me go back. I was saying we're waiting for much of the detail about how the government will announce the amount of 5.4 billion, which seems to be allocated for social care out of the new money. I know there are concerns about how money can be moved across from the NHS to social care once that spending is embedded. So that seems to be one of the big questions that people are asking. And I and my colleagues will, obviously take issue with how the money is being raised. But there is one thing to say at the start of our discussion today, that bringing together health and social care, at least in name, under one levy is important. It does reflect a wider shift towards collaboration and integration. We've known for some years now that patients cannot receive the best care when different health and care systems are competing with one another. And that's the situation that we've been in, because that creates burdens and unnecessary pressure, particularly on the staff. Our discussions on these issues today will shape the recommendations of our inquiry. They're an important opportunity to influence the changes to the healthcare system which are being determined in the coming months. The Committee for the Health and Care Bill met in Parliament for the first time yesterday, and now we hope that the long-awaited white paper on reforming social care may be coming before the end of the year. So I'm pleased to introduce our panel of experts by experience and experts by profession. I will ask all of our speakers to give a brief 3-minute introduction before opening the discussion into a question and answer session with our parliamentarians. To begin with, we will be hearing from Graham Price about his experience of accessing social care. Graham has been an expert by experience at Birmingham City University for the last 3 years, and he is chair of his GP practice patient participation group. We will then hear from Aisha Edwards, a self-advocate on Lewisham People's Parliament and a member of the Right to Home campaign. Aisha will talk about her experiences and views alongside Rachel Hall from Learning Disability England. We'll also hear next from Gavin Terry, who is Head of Policy for the Alzheimer Society, the UK's leading dementia charity. And finally, Ruby Peacock will be speaking as Head of Policy and Public Affairs at Carers UK, a charity providing carers with advice and support. And I am very pleased that I'm being joined by my colleagues, Margaret Greenwood MP, Damien Green MP, and my fellow member of the Health and Social Care Committee, Sarah Owen. So as I say, I'm first going to ask each of our witnesses to make some brief opening remarks, and then we'll move on to questions. Can I just say to our panelists that at the start, is that you don't have to answer any particular question if you don't have an answer. And if anyone feels that they want to email an answer or a written answer after the session, if they feel more comfortable with that, that will be fine for the evidence that we're gathering. So let me hand over to Graham Price to give us his 3-minute introduction. Graham.
Thank you, Chair. And I'm so sorry you've come to me first, because I'm cowardly wanted someone else to go first, but never mind, someone has to be first. So here we go. Just for everyone's benefit, who doesn't know, I am a totally blind 81-year-old person. I live independently alone, and I'm a member of Basra's adult group, and I'm very pleased to be so, as well as what the chair has indicated. First of all, I'm a bit disappointed that we've got to the Health and Care Act ahead of social care and public health reform. I wish we'd done those two first, because I think their need is great, and I just feel that this act might well constrain their reform. But however, we are where we are, and I can't change that. I am a bit concerned that with this act, we're giving the Secretary of State more powers that aren't going to, with less scrutiny, as well as discharge to assess being variable. These are rather concerning elements, and coupled with the revolving door here, the change in the health service, the health and care service has been enormous. I've been a patient rep from practice-based commissioning in 2008 through to Health Watch. I was a trustee for 12 months. I left because it was tokenistic. Went into the CCG as a patient rep in Sandwell, which was fantastic. Now that's being regionalised into the Black Country, but all of them, with the exception of the fact that I have no means of measuring, have been underwhelming in their delivery, in my view. None of them have, been within budget. They've all, not lived to promise. That they've overpromised, underdelivered. And frankly, I don't know how the patients or the citizen, because all citizens are patients, have been able to keep up with this. It's quite a struggle. The when and the why and how, considering they're supposed to be at the centre, the patient is supposed to be at the centre of the service, I find that rather a difficult concept to accept, really. However, I can't, and of course, as for innovation, I haven't seen a great deal of that. We were doing things in the practice-based commissioning that the CCG started talking about 6 years later. So, excuse me for being a little bit sort of pessimistic about these changes we're constantly under. I do accept the pandemic has caused a change to be much more relevant to us, that we really have got to do something, because both care and health services are absolutely under-resourced and they're breaking point. So something has got to be done. However, I'm not really here to talk about what's gone. I'm here more to think about what's coming. And as the chair said, a lot's been happening in the last several hours, but it is so beyond my scope to understand. We're still waiting for the detail to be given to us for us to be able to make sense of it, if we can then. But at least at the moment, it's in the ether for me. So I'd like to just turn back down, then go on to where, what I feel about where we are. But whenever I'm trying to grapple with a rather complex issue like this is, I just go back to the 3 involvement framework that BASRA has adopted. And that's principle, purpose, presence, process, impact. And no one would argue with the principle. Having joined up action in one place, delivering a service, as the chair's remarked upon here, that will impact upon the quality of life we go on to enjoy is important. It allows for joined up thinking, joined up, sharing of knowledge, really, and therefore engaging more fully with people. However, I'm a weeny bit concerned with this act in that it has a really strong health bias and a rather low social care balance. As to purpose, well, of course, the purpose is to deal with the neglect that's so long been with us, the broken promises, and of course, the desperate need to support both services that are in a calamitous state. But we have to recognise that they are different services, and that it will only have a good outcome if we value them as different services, that is, social care and health, and that we actually practice a good partnership arrangement in the delivery of that service. Then we get to the presence. Well, someone has dreamed up this, I don't know who it was, but as a person has taken a very keen interest in the health service, as I've indicated, I've been involved since 2008 in one aspect or another of it. I'm wondering where I fit in. Where do people like me fit in its delivery, in determining how it's rolled out and delivered? As for process, well, that's where the outcome will really arise from. But if we look at this act, both the Integrated Care Partnership and the Integrated Care Board don't have any provision for engaging with the citizen. They may do, but they're not obliged to. And I think that's a serious flaw. After all, how can the person be at the centre of the service if they're not engaged in the process? It just seems mad to me. Then we're on to the impact. I am very concerned at the imbalance here. It is definitely a health-led service, or appears to be, and maybe others would argue with that, but it seems to me to be. And so I'm very worried as a person with, or indeed, within a community of people with disabilities, we thought another, well, I ought to have said it, I'm a bit concerned because of the medical knowledge, medical slant here, that the medical model will appertain, or that the care arrangement will become medicalised. And frankly, as a person of a disability, I'm concerned we spent so long trying to ensure the social model of care is adopted in our service provision, which builds upon assets, strengths, aspiration, to give us, to ensure we can live independently, give us lives that we value. I appreciate that that both services, care and health, need resources desperately, and both have been under-resourced, but one much more so than the other. So we have to be careful here that when we're actually delivering the service, we recognise it's worth not weight.
Thank you, Graham. Thank you. I'm going to have to move on because this is meant.
I was just finishing there and saying fairness is a value we should operate here, and thank you for listening to me.
No, it's okay. I think we will come back to some of the points, and I think you've made some excellent points there. We will have a chance to come back at those with the questions.
Sorry if no. Clearly, thank you.
I understand, but thank you, and I've been making notes of your thoughts there. Can we come to Aisha next? Aisha, could you talk to us for a couple of minutes?
I come from a charity called Lewisham Speaking Up, and what we do is similar things. We like healthcare and stuff, and we do lots of like big groups and parliaments, and I'm one of 6 reps. What else? I'm just trying to think. We just do like similar things to what you do, and we're really concerned as well, because like the money just I know it's a big thing to have, like health and social care, but like for me, I would like to know, like for me and my organisation, we would like to know like how it's getting spent and what we can do to help. So yeah, that's all I wanted to say. Yeah.
Okay.
And I do many other things apart from that. Yeah.
Thanks, Aisha. Thanks. That's really helpful. Let me move on to Gavin Terry from the Alzheimer Society, just to give us a 2 or 3 minute introduction.
Sure, thank you, Barbara. And I think a lot of what Graham already covered was like really pertinent. So I hope that I could just add to that. So from our perspective, as you said at the beginning, we're the country's largest charity for people affected by dementia. And people born today have a 1 in 3 chance of developing dementia, but due to the limited range of clinical interventions available, most people actually draw on support through social care and healthcare. So our view is that integrated care is fundamental to quality dementia care, and we've welcomed the proposals in the draft bill for continued development of the ICSs, and we see those as a significant and positive step forward. Similar to Graham, though, it's difficult for us to comment on a bill that seeks to integrate health and social care when we're as yet unclear on what the future shape and format of social care will be. And as you said, yesterday's announcements and the subsequent plans, they're something that we will be looking at really closely with regard to how those proposals will impact, particularly on people affected by dementia. But our overview is that the bill is largely driven from the perspective of NHS resources and priorities, and therefore it kind of misses the opportunity to build that real partnership between care and health that's built on equity, which would enable people to live their lives the way they want to in the places that they call home and in communities where we care and support about one another. And effective and efficient integrated systems would sustain and improve the diagnosis and enable the delivery of comprehensive post-diagnosis support for people with dementia. I mean, we hear from people all the time about how difficult it is to access a system which is essentially put in place to support them in a time of often great need and vulnerability, and how the current system is a complex web that they have to navigate and endlessly repeat their story and end up sort of situations where they're duplicating what they're saying to get what they need, and in many cases, sadly, still unable to. But that said, there are welcome steps on enhancing co-production for people with lived experience. The voluntary community and social enterprise sector, so our sector, is actually a key policy making and strategic delivery partner, and a direct route to gaining the perspectives of people with lived experience that can contribute to the planning of services. So just as Graham said, an important part of actually talking about what's happening in a local population, reflecting what their needs are, and actually helping to plan and deliver what's on offer. But we'd like greater recognition and a duty to include representation of our sector within ICS structures, and in that way the bill would then be consistent in its references to the contribution that our sector would actually make. But aside from the structural developments, obviously the key thing that we also welcome is the inclusion of the duty to improve quality of care. And that really is the fundamental thing, recognising the importance of personalising care that helps individuals have choice and control. For example, setting their own goals for support. That could be a guide to frame people's overall or holistic needs rather than just their medical ones. And this could also incorporate a duty to increase access to support for more people. And essentially that would help to meet their particular levels of need. But we need guidance that clearly defines what quality care is. For example, what does having choice and control mean? What does it mean to have support to stay part of your community?
Yeah, I said I'm special. I told everyone I'm special. I said, Debbie, man, you're so, yeah.
But I love my job.
And
I
also,
the kids. Yeah.
Oh, that's good.
Yeah. As I say, I'm seeing them now.
Can we, Aisha, can somebody there help with muting? That's fine, thank you. Yeah, sorry. Yes,
no problem. That's right. So just to sum up, the focus on personalisation should also incorporate stuff around the individual personal budgeting, self-directed support that gives people clearer opportunities and maximises their rights as well. But in conclusion, our view is that the way to achieve effective support for people with dementia is through this emphasis on integration and personalisation. And we know ICSs will need to prioritise dementia if they're going to support people affected by it. And the exceptional position of a condition like dementia, where, as I said, people have to seek support from both health and social care, means that we think the success of these reforms can be judged by the impact on the lives of the 850,000 people with dementia and those who care for them. So that's just a statement I wanted to make, but I look forward to the rest of the discussion. Thank you.
Thank you, Gavin. And could I finally come for an introduction for just a couple of moments to you, Ruby, from the perspective of Carers UK?
Yeah, and I'll try and keep my comments brief, and I focus more on the integration side rather than the announcement yesterday. So just to start off with kind of the role of unpaid carers, NHS and social care depend heavily on the role of unpaid carers in looking after people with long-term illnesses or disabilities. There are 1.4 million people providing 50 plus hours of care a week. And we estimate that during the pandemic, there were as many as 13.6 million unpaid carers across the whole of the UK. It's a huge issue, and it's an issue that the health and social care system cannot cope without the support that they receive from unpaid carers. They also play numerous different roles. They are both administering medication, they are supporting daily life, such as eating or moving. They provide cognitive support, but they also provide complex and specialist nursing care to the person they're looking after. All of this obviously depends on the condition of the person they are caring for. Often this comes at a significant personal and health cost for carers, and unpaid carers more than twice likely to be in poor health than the general public. Just to add to some of the things that Gavin said, I think one of the biggest frustrations we find from our members about lack of integration, both across systems and across the health and social care system, is that repeating information. They find that they are repeating and repeating and repeating what is often quite difficult stories, and they often describe their want to get help from both health and social care systems as a battle. And that's not how we want to be providing that holistic support to people. There is also a disconnect across health and social care systems. So social care systems have some duties towards carers and their well-being, but the NHS neither has to systematically identify carers nor does it in any of its legislation have to have regard to the well-being of carers. We found that this often means that carers get missed out, whether that is when NHS England or other NHS bodies are consulting about services or delivery of services, or when we look at things throughout the pandemic, often carers have been missed out of communications. So for example, lots of the vaccine communications, despite unpaid carers being one of the priority groups, really did not say that loud and clear to people. And part of that, we think, is that this bill is an opportunity to place a duty on the NHS to have regard to carers and to give more parity of carers' rights across the health and social care system to improve integration. And then just finally, I wanted to end on a point. The health system doesn't function without social care, and the social care system does not function without healthcare. We have seen the challenges of both throughout the pandemic. And one of the things that we found is 78% of the people of our members have said the person they're looking after's condition has worsened. And they point to two major factors for that. One, they have not had day services or social care services that they used to have. They're doing more lifting themselves, they're not lifting appropriately. Or they are not getting the communication or the washing that the person used to get previously. They also point to healthcare. They've had a reduction in terms of physiotherapy or small, wider services across, and all of that has had an impact. We need both of the services to work effectively if we are to provide a big package of care to people and keep their conditions as well as we can. That's it, thank you.
Thank you, Ruby, and thanks to all the panelists for their introductory words. That's really helpful to kick us off. And I should say, in terms of what you said, Ruby, that I did have a private members bill on the identification of carers and having to have regard for carers' welfare, and I've still got the bill, so if we could somehow persuade for that text to be included in the health and care bill, then that would be a great thing. Let me just kick us off with our more general questions then, although I think certainly we did have a number of really useful observations from Graham as he started, and particularly the levels of change in health and care, which are enormous, and of course even the pandemic has caused much more change than what we're all planning to have. Let me put forward a straightforward question first. What will work better if health and social care work had joined up? So who wants to start? Aisha, could you tell us what you think would be better if health and care work together?
I think it would be just everyone just work together. Everyone work together and just make it better, like more training and stuff.
Okay.
Yeah, just more training and just everyone just come to an agreement and just try and just see what other people want.
Right. Okay.
Yeah.
Thanks, Aisha. Thank you. Thanks. Graham, thoughts on that? What will work better if health and social care work are joined up?
What would be the benefits of
Yeah, what would be the
together? Well, I mean, it's possible that we would need less, what do we call it, the admin element, I've lost that word, but that doesn't matter for the moment. I mean, it'd be a more holistic approach, which has got to be better, more joined up. Duplication, should be less, if there is any, evident. I like the idea because these two services are closely associated, as has been made clear, I think, in Gavin's address. But one is, the one is to treat and the other one is to support in generality. I know the health area does also have what you might call support elements as well, like the therapist element, but on the whole it is to treat someone, whereas the care is to support. But I do think they are very, very closely interrelated, and they're both necessary. So to enjoin them does bring real benefits, providing both parties are properly valued at the moment, I'm a bit worried that they are. And certainly when, you know, I sat on the adult group when we discussed with the subgroup, discussing the discharge to assess. And frankly, what we found is that those nurses who've been in a really good hospital, or hospital, where there is real value given to their presence and involvement, they're very keen on this integrated process. But those who felt themselves out on a limb, where they found clinicians making decisions which they felt should be more correctly left for them to decide, have felt very unhappy about the integration process. And so there are some doubts here about how well it will work. But I think the principle is really good, and we ought to be, going along that route.
Thank you, Graham. Gavin, could I come to you?
Thank you. Yeah, and I suppose just to build on that point, yeah, I mean the holistic approach would be the main benefit, and the real recognition of people's health and social care needs. I think what we see, particularly with people with dementia, is that point of diagnosis is very medical. It is, after all, a medical condition, but most people receive social care as the support that they get. But it's the joining up from that part of the process. So from the point of a good quality timely diagnosis of their dementia to then accessing post-diagnostic support. And so the joining up of health and social care would firstly enable, as we've already talked about, that reduction in duplication and repeating stories would help to get people to where they need to go, but would also help on the health side, I suppose, to sort of help them to understand where to signpost people to, because at the point of diagnosis, people have very, very different varying needs depending on the type of dementia they've got, how old they are, whether they're still of working age, how advanced their dementia is. And so that all needs to be taken into account. And I think it's that kind of, for primary care in particular, who manage a lot of the diagnoses, it's onwards referral to memory assessment services and memory clinics for more in-depth diagnosis, but then how people are then signposted on to access the support that they need. And that's the bit that I referred to, which becomes the kind of complex web of care, where people have told us previously that they've had to have more than 20 conversations to get to the point that they need, and then it's still not quite what they want, and they have to start again. So I think that's the biggest benefit, but also the real recognition of people's levels of individual need, and enabling them to access tailored support that actually meets their personal needs and is right for them. So again, age appropriate services that help to support their carer, all of those aspects of the care and support that they might need at the point of diagnosis and then onwards into their dementia pathway.
Okay, thanks. And finally to you, Ruby. Colleague Margaret Greenwood, I'll come to you next to take over the questions if you like. So Ruby, if you'll help us with this.
Yeah, I'll keep mine short, because I think Graham and Gavin have brought in kind of a lot of what we would say, but it is about having a holistic approach and recognizing that lots of people, even when they have health needs, also require social care, and that social care service is dependent on keeping their condition, dependent on helping them with their condition. So when you're having a package of that support for you as a family or for you as a person receiving care, you don't always split everything into health and social care services, because that doesn't make sense to you. That makes sense to us because we've designed the system that way. And if we can have greater integration, we can start to talk to people about how they want their care as a whole to be given, rather than separating everything out into health and social care services.
Thanks. Can I come to you, Margaret? I'm worried that Sarah's going to be with us until 4. So if I ask you to ask a next question, then I'll come to Sarah.
Lovely. Thank you very much. And thank you to all the panelists for sharing their thoughts and experiences. It's really interesting. So I was interested to hear, Graham, you mentioned that you were concerned about discharge to assess, and in discharge to assess being this idea that people should be discharged from hospital before their social care needs have been assessed. I just wondered if you could expand a bit on why you're concerned about that.
Well, I'm concerned because I don't know how one can discharge someone without knowing what their needs are. And that means you do have to assess their needs. And rather interestingly, before, when I knew I was going to be a panelist here today, I rang up 3 people I know, 2 of whom well, one is my brother, so he's clearly quite close, lives in Worcester. The other one is a neighbour across the park. I'm the vice chair of the Friends of the Park group, and he's a treasurer who's just come out of hospital. And the other one is my 91-year-old neighbour 3 doors down, who's been discharged. And 2 of them, my brother and the treasurer, haven't seen, did not have any social care intervention whatsoever in their discharge. Just the consultant said they were going to be discharged. Now, and the one, my brother in Worcester, has actually he's been out 5 weeks after a triple bypass operation, and he has not been seen by a social worker in 5 weeks. There has been no contact whatsoever. It's unbelievable. My neighbour down the road is 91. They were going to discharge that elderly lady whose home is really not fit for purpose and still isn't, but she lives in it independently because she's determined to do so. But it was only because she had a young friend who was prepared to really raise havoc to say, look, you can't discharge her. Has anyone visited the home? No one had, of course. And so, frankly, I just find it impossible to believe. I do see there's some value in a continuation of the assessment process. That is, they are visited and it is really observed and understood that their care needs are being properly met, or at least they have the opportunity for them to be cared. I mean, my 91-year-old, did away with the care as soon as she had to pay for them, even though she could afford to, but she decided she wasn't going to. That's her choice. But at least that assessment and that need to continue assessment is important. So I can't see how you could discharge without assessment. I mean, I was in hospital in 2018 as a 78-year-old, sorry, I wish I was 78-year-old, and I was discharged without any social worker intervention. But there we are. But I'm not talking about the present situation where this is now becoming, a point in the act where a person will be discharged, or maybe, because that's a variable thing, without assessment. I don't believe it should be done.
Thanks very much, Graham. That was really helpful to hear those examples. Thank you.
Is it possible to just quickly come in on that point? Because I just wanted to highlight that we released some research yesterday on the impact of hospital discharge and the discharge to assess model on unpaid carers. We found that 81% of carers said they had no communication about what sort of care and how they can continue to care safely for the person that went on discharge. And 66% said they weren't asked about their willingness to care or felt listened to about their willingness to care. We've had some really quite difficult stories about people being discharged without really any communication from the hospital at all. And that often meaning that they weren't providing the care that they were supposed to for the person that they were caring for, and they just didn't know. Things like they're supposed to wear compression socks and they weren't told, or they need to take medication at certain times and things like that. So I'm happy to share that with the group afterwards.
Thank you, that'd be really helpful. Thanks, Ruby.
Yeah, that's great. Does anybody else have anything to add to that, or shall we move on? We have got lots of questions, so let's move on.
I just wanted to make just an additional comment.
Yes, Gavin, yeah.
Thank you. So yeah, I mean, I agree with what Graham said, that it's essential for people. I think from the perspective of people with dementia as well, we've spoken before about the fact that up to, people in hospital could be up to around 50 or 60% of anybody in hospital with dementia at any one time. They often stay in hospital twice as long as people who are in there with having other things done or other conditions. But they're also subject to significantly longer delays in terms of discharge or transfer of care. And in terms of that, so planning for discharge would be essential for people with expired dementia, not just in terms of any needs that they might have at the point of discharge, but in case their needs have changed, because the other risk of them staying in hospital for longer periods and the care that they receive is that we know that people's dementia can significantly deteriorate the longer that they're in hospital. So in terms of planning for discharge, it's not just about maybe what they had in place and some tweaks to what they had before they went in, but it could be a completely different package of care altogether. And also, as we said there, with the support carer as well would, could quite possibly change as well during that time. So just wanted to add that point in as well from a particular perspective.
And Chair, could I just, what I didn't say was I think that assessment absolutely should be made by a social worker, not by a clinician.
Yeah,
The skill levels are different, and we ought to recognise that.
Yeah, thank you, Graham. That's a good point. Well, let me come to you, Sarah, because I know you have to leave us at 4. So could you take over and ask a question at the moment?
Thank you, Chair. And I'm sorry, I do have to leave just a little bit before 4 to get to where I'm going. But I wanted to say thank you very much for all of your panelists today. It's been really, really useful information. And I wanted to follow on from Margaret's point, really. When we heard at the Health Select Committee from a gentleman living with dementia, he felt, and he said quite clearly, that he was tired and his family were tired of fighting the system that should be trying to help them. So when we are talking about greater integration between social care and the NHS and health services, what I'm very keen is that we do not create, that we can try and slim down the levels of bureaucracy that patients and relatives of patients and people that are trying to access care have to jump through. So I was wondering, and I'll ask Gavin first, because it was particularly acute with this gentleman that we heard from as a witness to the Health and Social Care Select Committee about how they felt that they had to keep repeating the same information to different organisations and how integration could actually solve that problem, and if there are any pitfalls that we actually have to look out for as well. Thanks, Gavin.
Thanks, Sarah. Yeah, I think what we talked about before in terms of this is that the obviously at the moment the cultures of NHS services and social care are very, very different, but then sort of underpinning that, the infrastructures are very different as well. So there are very, very practical things that are just clearly communications and like things like computer systems that don't talk to each other. So the sharing of information and data is one of those things that fundamentally is responsible for people having to keep repeating their stories. But there's also the kind of the human element in terms of how health teams and social care teams or different aspects of services actually physically or link up and talk to each other about patients and their needs. And whether there are sort of local champions that kind of bridge that gap, or whether there are other mechanisms that can enable sharing of data and information so that people don't have to duplicate the stories and keep saying the same things over and over again. But one of those is, the role of care navigator is one that's been mooted in the past, so that is a kind of a role that bridges across health and social care and brings those services together. But what we see in reality happening is that, health thinks that the social care team are looking after everything to do with social care, and the social care team seeing that the health team are just doing everything to do with health. So, for example, one person that we heard from was about having outpatients appointments, but wasn't getting support from either the health side of things or social care side of things to attend their appointments. So it ended up not attending any outpatient appointments, and this was for another condition altogether as well. Ended up not attending any appointments whatsoever. So it's things like that. It's not even just the stuff that's specifically related to the person's dementia. It's about managing any other conditions that they've got, their prescriptions, medication reviews, all of those kind of practical things. So aside from the fundamental issues that we've been talking about in terms of what their aims and goals are for being supported and getting access to care, there are some very practical day-to-day kind of infrastructure stuff that needs to be sorted out as well. And I think those are the things that are in danger of being ignored as well, or not ignored, but maybe the focus will be on how to join up services on the front line, but maybe not looking at some of those back end systems that help to really, really facilitate that.
See, Damien, you've got your hand up. Did you want to come in with a different question?
Oh yeah, I've just been told that the health secretary is doing a briefing at 4, so I will have to disappear at 3 minutes as well. So I suspect I should be there. What I was going to ask is, and one of my fears, frankly, for the whole integration process, which I'm sure is very well intentioned, is that the health service voice will end up much stronger than the social care voice in around any of the tables that matter, presumably at a sort of regional level, where the integrated system will come together. And I just wondered if any of the panelists had a view about how we could try to avoid that, to make sure that it's genuinely a partnership of equals rather than something that's just dominated by the big battalions of the NHS.
Who do you want to kick that off with, Gavin or Graham?
Graham, do you want to have a go at that first?
Okay, I will. Damien, I think this is a really difficult, well, it's really the most important element, I think, about this whole integration process or proposal. It's going to be more than a proposal, shortly. How do you do that? We only do that if we really begin to think in terms of whether value is worth, not weight. We only do that if we will only motivate people to contribute to anything if they feel that they're in a fair system. If a social worker is in a system where the health worker reigns supreme as a top dog, whose ego is rather bigger than you name it, then I'm afraid it will fail. I'm afraid that is what will happen. In fact, one of the things that worries me now about this act and engagement is that 80% of what's going to be raised under this taxation system is going to go to that. Is dealing with the backlog in the health service. And so clearly they're going to be, and then at some point they're going to then discuss how they make a better divvy of this resource between health and care, social care. And I can't see it happening because that will be in the election year. So straight away they'll be saying, and health is, most people think the National Health Service does everything for them. The care element, they just think is, well, that comes along. But it doesn't come along. It has to be planned for. It has to be thought through. And hopefully people will really be sufficiently humane to realise that what we have to do is value the different skill sets at play here, and that the multidisciplinary approach is what will operate. And everyone sitting around that table, they won't be delivering, they won't have the same input or weight of input, but they will have a valued input, and they must be judged to have that valued input. That's the only thing I hope, is that people will, well, maybe if the government brought in a process where best practice would operate, and providing whoever is in the position of basically making sure things happen, says we will operate that system where the social care has at least equal value, if not equal weight, because it is very important that they work well, and only fairness in that application will make it work well.
Thank you. Gavin?
Yeah, thanks, Damien. I mean, so in our response to the bill so far, what we've emphasised is the need for this to be an opportunity to enable that greater parity between different parts of the system, and that the language within the bill overtly kind of promotes a sense of partnership, so that social care actually is well represented. I think that interpretation that we talked about at the beginning is that it mustn't be seen to be being led locally, like within the structure of the ICBs and stuff. It shouldn't be seen to be being led by NHS or local health, with other people kind of falling in, but should be equal partnership and have that equal level of participation between health, social care, local commissioning, and, as I said earlier, the voluntary sector as well.
Okay, Ruby, have you got anything?
Sorry, Damien, could I just add one thing? I think one thing we could do for it, sorry, I must allow you to allow me to continue.
Carry on.
Am I okay? Thank you. Damien, one of the things we might start doing is ensure that care has equal prominence in what you might call the news briefings. We talk about the Secretary of State for Health. We forget the and care bit. You know, whenever I listen to radio before, it just said Secretary of State for Health is doing it all the time. If we leave care as, if you like, not important enough to even mention, how on earth does it get into the public domain where it is an important element?
Yeah, I'm afraid one thing politicians absolutely can't. One thing politicians absolutely can't control is the way the media report things. If we could control that, they'd probably report us more positively, let alone anything else. But Ruby, did you have anything?
Just to kind of add, obviously, parity of esteem is really important. And I would agree, I think both Graham and Gavin have picked up the importance of language, and that comes from kind of from the very top all the way down. But I think the guidance in the bill really needs to show that integration and to put them together as a collaborative approach rather than health. And then we mentioned social care slightly further down the paragraph, which sometimes can happen. And then the makeup of the ICB is so important, and thinking about how we choose the chairs of the ICBs, because their role there is to make sure that there is equal participation from health and social care and that they're treated equally.
Thank you all. That's really interesting. Thank you.
Thanks for your question, Damien. And I think there's a point to be taken, forward from yesterday, which is that I know that carers organisations pointed out that unpaid carers were not mentioned in the statement and hardly at all in the documents. And I think given the reliance that we've had on those 13.6 million unpaid carers, then it's right that your organisation should point that out. Let me ask the panelists another question, then I'll come back to you, Margaret, if that's okay. Yeah. If there is, I think we're getting to this in what's just been said, but if there is one message about health and social care working together that you could say to the government, what would that be? Who wants to start? Do you want to start, Gavin or Graham?
I don't mind. I think we've all just agreed that social care and the NHS on an equal footing is the key one. But I think just building on what Graham just said actually about that kind of, I suppose locally and nationally, it's that awareness of social care as well. And there keeps, the phrase that's oft used is about having a national conversation about care. But so far, nobody has seemed particularly eager to grasp that nettle. And that's a question that I think that's been going around for years, since maybe even the Darcy review, is about, having a national conversation about integration and health and social care. And I think the thing is that, particularly for the people that we represent, everybody kind of understands and grows up understanding what the NHS is. The kind of the press media view of like investment in the NHS and social care as a broken system. But we find in our experience, the people that we talk to, they don't really know what social care means or what it entails until they're at a point of crisis and they absolutely have to access it. And then of course there's the issue of having to pay for it as well. So I think a lot of the discussions yesterday on radio programs was around people's assumptions that their national insurance payments were already going to help fund social care. So there are these misconceptions, and I think that's one thing that the government absolutely has to sort of tackle in terms of that level of awareness around what social care is, what it does, and to kind of bring it up from this this perceived broken system, which is like needs to be fixed, into something that equally needs to be invested in and protected and developed.
Okay, we haven't heard from Aisha for a few minutes. So Aisha, what would you what's the single message you would say to government about health and social care working together?
Like it's just like everyone just getting to know each other, because this is where the training comes in. Yeah, I did. Yeah. This is what I just getting to know each other and stuff, and just like trying to be understanding. Why does everyone have to fight all the time over money? Nice, like, I know it's hard and everything, but everyone just pulled together and not pointing the finger, who did this, who did that, who did this. It's just, you know, that's all I want. Just everyone to work together, have some sort of training. Oh, and get someone with a learning disability in there as well. Yeah, that understands the system and, you know, that can work alongside, and everyone just get along and play nice, you know? Yeah, that's all.
Thank you. Thanks, Aisha. Shall I come to you, Graham?
Okay, well, mine's very simple. I quite like Gavin's approach to it. Mine's a bit more direct, really. And that is, mean what you say and say what you mean. Be honest and properly open with people. People are very understanding, even forgiving of things that don't work well, providing they feel they're being taken on board in a mature way. I mean, for instance, if you're standing on a platform waiting for a train, and no one bothers to say why it isn't there, and it may be late, they're very much more forgiving as long as they're informed about what's happening. And I really feel that, you know, that's the message I would always give. I mean, about 5 years ago, I gave evidence to an all-party group on the employment of disabled people. The idea of the government was to try and reduce the level by 1 million. But at the same time, they were not prepared to increase the funding for the access to work. Well, how on earth you get people coping with disabilities to work unless you increase the access to work funding is beyond me. So that's really what I mean, is be honest about what your endeavours are and mean what you say and how you say it.
Thank you. And Ruby, what would your message about health and social care working together be to the government?
So just to kind of add to Gavin's point, I think even with the basic understanding of social, like not a very good understanding of social care, that understanding of social care relates to older people and people with dementia, and we tend not to think about social care for working age disabled people. So there is even further to go to get that understanding amongst the general public and that understanding across the media about what that level of social care, of what that bit of social care looks like. But more than anything, I think what the people we represent want is quality care. We often talk about the kind of the catastrophic costs, which are terrible, but it's the quality of care that matters to people and their families. And unless we improve that quality, we won't have a system that works for people.
Thanks, Ruby. Margaret, can I come to you for the next question?
Yes, actually, I'd like to ask a question following on from what Ruby's just said, and that would be to ask how can we improve the quality of the care that people receive? What would be the main thing that would make a difference to people? Maybe if Ruby might like to start.
Shall I start?
Yeah.
So I think what people like is a personalised service, and it does work different to the NHS. There is much more personalisation in social care, and people want to keep that. But I think there is a professional development of staff and the level of pay of staff makes a big difference to the quality of care. There is the overall level of funding that is available. And I think there has to be a recognition now that lots of kind of small charities and groups that were providing a whole variety of services before the pandemic have been under an enormous amount of pressure and difficulties with funding. And we need to find a way of building those back up if we're going to provide that personalised option to people.
Great, thank you.
Just me?
Yes, Graham?
Oh, sorry, I didn't really, sorry.
Sorry, yes, no, please.
Sorry, thank you. Yes, I think Ruby has got it dead right, really. I mean, it's valuing people. And the other thing that and personalisation has definitely made a difference here. But I mean, for instance, under the austerity, which by the way, no one is boasting about any longer, you know, we have lost a great deal of what you might call superior group mechanisms. A lot of these small community groups that supported people to ensure and, you know, have a quality of life have gone because they were basically supported by local authorities who've been hammered. I mean, they've just been literally starved of funds. And what do? They just say, what is it that we don't have to do? And of course, they don't have to support these community groups that have really, you know, supported, have been the bedrock of support for people who needed a bit more support, particularly on a social basis, to ensure that they don't become extremely lonely and isolated. So I think, you know, I think that's one of the ways we can deal with ensuring, you know, the quality is addressed. I think we've got to be careful not to think only of, you know, it's a bit like sometimes people get a little bit hot off the collar about the support we give to disabled people to enable them to survive. But we're beyond surviving. We want to thrive. And that means being given the means to do it. And so this is, you know, these are the important elements really, that we think in terms of standards not being the minimum. We think of it being what we ourselves would like to have to enjoy a life.
Thank you. Thank you. Gavin, I don't know if you have something you might want to add.
Yeah, something on just a slightly different tack as well. It's just that as an organisation that funded research, we fund research annually, not just on acute dementia, but also around developing models of care. So looking at what the future aspects of care can be, or revolutionary types of care for people who are living with dementia now. So we were particularly interested in the duty in respect of research being promoted, or opportunities to take part in research being promoted for people who are using services. Because we know at the moment that engagement from people, particularly with dementia, on dementia research is quite low. So that means that there's a kind of, at the moment, there are a few evidence-based care interventions. There are some that are in development that, you know, we do have engagement in, and we've got stuff coming out in the next couple of years. But this could, you know, promoting those opportunities locally as part of, you know, the future of care would be something that we would want to see really sort of pushed in the language in terms of promoting those opportunities.
Right, thank you.
Thanks, Margaret. Let me come to the next question really, and it's about how can the voice, views and wishes of people who use care and their families be heard? Can I ask you, Aisha, how do you think we can hear from people with learning disabilities about the things that are not working well in health and care?
You know what I was gonna say, like, just ask the person how they're feeling. Ask the person how they're feeling, because if you don't ask, you don't know. Yeah, if you don't ask, you don't know. So go to the person. Don't, like these bosses, they seem to think that they know everything, but they don't. They really don't. Just go and ask the person, because we know best. We live by lived experience. That's all. Yeah, so that's all I want to say. Thank you.
Thank you, Aisha. Thank you. Thanks. Can I ask you, Graham, how do you think the voice and the views and the wishes of people and families should be heard in as we work on trying to bring health and care together?
You know, Chair, I've written my response to this, and I've forgotten what I've written, and I'm trying to think desperately what it is I've written, because I have to put everything in my memory bank. I can't refer to anything once I'm...
Okay. Do you want me to...
Can I send that to you?
Yes, absolutely.
Value people, you know, to really make the person the centre of the service, and that once people feel valued, they seem keener to engage. And that's extremely important. Can I send my response?
Yes, please. That would be great. Ruby, can we come to you? How can the voice, views and wishes of people and families be heard, particularly carers, unpaid carers?
I think too often carers find that they're not treated as partners in care, and often what they play such an important role, and they are so essential to keeping that person healthy and well, that they need to be more involved in those decisions. Obviously, there needs to be safeguards and caveats to make sure that you're not sharing information that the person they're caring for doesn't want to be shared with them. But I think too often they find that it's really difficult to have those conversations with either healthcare services or social care services, and their role isn't always recognised. And I think we find that is particularly true with different relationships. So often parents of disabled children find it much easier to have those conversations with both health and social care, whereas some of the people who are caring for parents, or even people who are caring for their partners, find it more difficult to have that conversation because it doesn't fit in people's model of who should be the person they're talking to about stuff.
Yeah, thank you. Thanks. And Gavin?
Thanks. Yeah, just to follow on what Ruby was saying there, I think the other thing about people in certain positions of care is just giving them different ways of communicating their views, and their making that as flexible as possible, so that, you know, because if people have got sort of work responsibilities and caring responsibilities, they might not be able to get along to a kind of open voice session or a particular gathering, but there's, you know, other ways through sort of like social media or you know, other methods by which they can sort of give their views. But I think that on the wider point, as we've already discussed kind of in the opening statements, is just the role of sort of like organisations like ourselves and the voluntary sector more widely, in that as well as providing local services and things that can actually help to support people, we're also that route to groups of people locally or regionally who are, you know, either wanting to or prepared to sort of give their views or give their time to actually talk about how services should be planned or developed, and that cuts across, you know, different communities as well. But I think the emphasis there should be that in the future with ICBs and a very localised focus, that we can actually help to channel the views of people in, which will help to give a very, very local view, which will then hopefully influence and help develop localised systems that meet local people's needs.
Thank you. Margaret, would you like to ask another question?
Thanks very much. Yes, I'd like to ask a question, whether people have any thoughts on if health and social care work closer together, whether there will be any difficulties that arise from that, or changes, you know, sort of unforeseen consequences from that. So looking at what the downside might be. I don't know who might like to start with that. Ruby, I don't know if you might be able to start. Have any thoughts on that?
Yeah, I think so. From our perspective, going back to kind of one of the first things I said in that opening statement, I think we don't have parity of esteem in terms of carers' rights across health and social care services, and we would be slightly concerned that it might mean that their rights are somewhat downgraded on the social care and kind of local authority level to kind of match the NHS, and what we would like to see in the bill is making sure that there is that duty to have regard to carers, so that you're seeing kind of equal treatment across health and social care.
Thank you, that's really helpful. Does anyone else like to comment on that? Anyone who can see any downsides?
So I was only
Graham,
I would only sort of reinforce what Ruby just said there. I mean, I think that's a real downside, is the unequal weight, it seems, in this provision, and that really does need to be addressed. That somehow we've really just got to start making sure that, you know, we value all participants in this process. So I think that's a real issue. The downside is that that every party to this process is valued equally, even though they'll be contributing at different levels.
Thank you very much. Does anybody else want to come in on that? Aisha? Oh, is she still there? She might have gone. Aisha, have you got any thoughts, Aisha, on, you know, if there will be any downsides if health and social care work closer together?
like maybe like money issues, like like money always keeps running out. Well, money is the issue of any job, because you might get something started and then you realize, oh damn, sugar, there's no money to refund it. So that's the issue.
Yeah.
And anything else, no, not that I can think of, but maybe like the equipment side of stuff as well, because they might run out of equipment.
Yeah.
So maybe refunding them that.
I think that's a really.
So we can get 280 from here and go to 2, can't we?
Yeah, no, I just said like
I think that's a really good point, Aisha. The money is crucial,
isn't it? It's crucial, because to have a good foundation, you need money, and to put it rootsly and get everything in place. Because there's no point having a good foundation if you don't have nothing to fund it with, and the right people as well, and training, those 3 things.
Great, thank you, Aisha. Thank you. Gavin, do you have any thoughts on that at all?
I mean, not too much to add, other than agree with what Graham and Ruby just said, that you don't want too much levelling of the playing field in terms of it then reducing the focus on those with the greatest need. Yeah,
I see. Thank you. Yeah. Thank you.
I think there's also another slight challenge here, and that is the people becoming a bit confused as to what is health and what is care, and where does payment step in. And that is one of the difficulties of integration, really, is that we've got one that's means tested and one that isn't. And that demarcation line isn't always that clear. Well, we know it's not that clear. I mean, we know if you have dementia, my late wife coped with Parkinson's and advanced Parkinson's and extreme dementia. And it's absurd, the fight you have to get health service provision for people coping with those impairments. Whereas if it was another ailment, it would go beyond question. And I think many people, for instance, might find themselves in hospital like Maura did, and then has to go into care from there. And then, did she qualify for continuing healthcare? Well, I fought for it and I got it, but many people don't get it.
That's right.
And it's a real issue. And I think that is one of the things that will come to haunt this thing, is that people not being too sure, where the boundaries are, the demarcation is.
I think that's a really interesting point, Graham. Thank you. Very, very interesting.
Thanks, Margaret. Well, I think it would be helpful if I threw it open to all the panelists now to ask you what you wanted to add, because we've asked quite a few different questions, but I know that everybody's coming at this from a different perspective. So can I ask you, that's the final thing, I mean, really just add on this whole issue of integration, and we've talked about culture and the different value systems and medical models and social models and all the things we've touched on. But what do you want to add? Let me come to you first, Aisha. What do you want to add to our discussion today?
Just everyone, just like as I've been saying, just working together, and maybe putting the training, and everyone getting to know each other, from doctors, nurses, everyone just working together and being in the same room and collaborating. That's all.
Thank you. Yes, that's helpful. Graham, do you want to
I would actually, thank you, Chair, because I was keeping one of my things back from one of the questions. The question you asked me a bit earlier, which was about how do we relate to families, or families relate to this integrated service. And I said, I've written something down, but I can't recall it. And I was saving for another question that's on that, on the list that was sent out, which was to what extent, I can't remember exactly how it's worded, but it's to how can we engage, how can we encourage people to become more engaged with the service? And I've forgotten what number question it was, but it's towards the bottom. And my response to that was, well, what we ought to do is make mandatory the requirement of oh, it's primary care. The question was about engage with primary care. And how can we make and to make mandatory the requirement of local practices to set up the patient participation groups. It is mandatory under the CCG group legislation, but it's not being practiced. And frankly, they're a whimper. It's supposed to be audited, but you know, doctors have been able just to go along and tick a box saying they do it, but they don't do it, or they do it in such a abysmal way that it isn't effective. And really, that seems to me the basis for really beginning to get engagement in the health and care process. That if we, you know, there's no reason why health centres are just dishes out of medicine. There's no reason why they can't be welcoming centres for, you know, a coffee morning, or indeed even associated with a leisure centre where people go. You know, it seems to me that's the route by which we begin to engage with the community at local level to encourage them to take a great interest in the services being provided. It's very interesting. The assistant manager for engagement in the Black Country CCG now approached me last week to say, would I mind being videoed? Because at the next board meeting, they're going to talk about public engagement. So, and the question was, what do you most want from your primary care? And the reason they were asking me to have this video was, he says, at one time we'd go on the street and we'd ask people if they minded being videoed for some promotion we were doing. That's when we had the CCG for Sandwell and West Birmingham. That's gone. We've now got the Black Country CCG, and it's in the ether. None of us know what's happening. But and he said we could go and ask people, and 5 out of 10 would say, okay, and they'd be videoed giving their comment. He said now it's less than 1 in 10 will be videoed giving their comment about the health service. Now, isn't that incredible? And I wonder why that is so. And I suspect it's because people feel totally disempowered. They just feel, well, what's the point of them having a view about anything? It won't change anything. It won't enable us to change things. If we make the patient participation groups effective, that to give the doctors a resource to do them properly, that will, I think that will begin to change things. I hope it will.
Thank you. Thanks. And Ruby, what do you want to add to what you said? On any of the questions, yeah.
I was just going to very quickly cover, like, I think there's real opportunities for the health and care bill and for integration to improve the experiences of carers and the people receiving care. There are just a couple of things that we would like, which I have mentioned. So one of them is making sure that there's that duty to have regard to carers in the NHS. I also think the guidance, the bill provides very limited detail about how ICB is going to run, and the guidance is so important to make sure that they are fully integrated, that there is equal partnership across those, and that they are delivering for the communities and the people that are receiving care. There are also, for the first time, consultation duties for NHS England to consult with unpaid carers as a specific group. And again, that's a real opportunity, but we need to make sure the guidance is right. And then just very finally, we just want to make sure that hospital discharge kind of recognises the role of unpaid carers, and that we make sure that we're providing safeguards in the hospital discharge if we go down to the discharge to assessment. And that's it for me.
Thank you. And Gavin, what would you like to add as your final thoughts?
Yeah, I think agree with everything that Graham and Ruby have just said, and Aisha as well. Just to reflect back on what I said in my opening statement, is just that sense of the complexity of dementia and the system as how people experience it at the moment. And we really believe that if that duty on real recognition of partnership working at a local level, and the integration of all involved, bringing in the voluntary sector in terms of the public voice and the voices of experience. That will be really, really key to solving this, in terms of providing the services that people need and that sort of personalised care that people want to be able to live their lives. And I think, just as you said at the beginning, again, in light of the announcements yesterday, a big part of this is around what the future of social care will look like, as that key partner in integration. So we'll be looking very closely at what that means for people affected by dementia and how it is going to affect them, so that we can continue to influence the passage of the bill with that in mind, and as we gain some greater understanding of what it means for the people that we represent. But hopefully, it will bring about that parity and putting social care on an equal footing with the NHS, so that it does go forward in a sort of truly integrated way. I think that's the position that we're holding on to.
Yeah, I think a absolutely key theme today has been about parity and putting things on an equal footing, and we know they're not, don't we? And I guess, Graham, that both Margaret and I, and probably Damien and Sarah, if there was to others, are receiving lots of things, kind of really raising issues with the way that primary care is working now for people, and commenting. I think it's very difficult. I think there's a big thing to resolve now, because primary care has had to go into this thing during the pandemic, of remote consultations, and I think people are now finding that very difficult indeed, or certainly the people that write into me about it are. But it makes everything we've talked about much more difficult in a way. And I think the final thing is, we know, don't we, that both social workers, care staff, and medical staff, as with unpaid carers and all your organisations, are just really reeling still, and tired and burned out. There's a great deal of that going on. And as Graham said at the start, there's so much change going on, and there's so much change that has been going on. It's very difficult to keep on top of it. But I think it's been really helpful to listen to your thoughts today and to have the questions. So I'd like to thank Margaret and the other parliamentarians, but certainly I'd really like to thank all of you. I'd like to thank you, Graham and Aisha and Gavin and Ruby, for bringing your thoughts to us and representing your issues. So thanks very much. So our third session, evidence session, is going to be next week, and then we will progress. But as I did say at the start, if you've got anything you want to send in to any thoughts about the questions that we had, we didn't necessarily ask the questions in anything like the order that we sent them out in, then just do send us your written thoughts, because that's useful evidence as well. And if your organisations or you individually want to make a submission, that's fine. But thanks to all of you.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everyone.
Thank you.
Alert, bezet met de meeting. Alert, speaking bezet met de meeting.